Good morning to one and all. This is in continuation with our e-content lecture series from Department of General Pathology, SRM Dental College, Ramapuram. So I'm Dr. Vishwaja. Today's topic of discussion will be on polycythemia. Coming to the definition of polycythemia. Now, polycythemia is defined as a condition which is characterized by marked increase in the total number of RBCs. So the RBC count exceeding 6 million cells per cubic millimeter of blood is considered to be as polycythemia. Now, polycythemia is also one of the myeloproliferative diseases. Polycythemia is considered as one of the four myeloproliferative disorders. The other three include chronic myeloid leukemia, essential thrombocytosis. Now, this polycythemia is a condition in which there is hypercoagulation of the blood. Now, the primary classification of polycythemia is as follows. Now, clinically, they are classified as polycythemia vera and polycythemia rubra. Now, the pathological classification of polycythemia is as follows. They may be divided into primary or idiopathic type of polycythemia, where generally the cause is unknown. The second pathological classification of polycythemia is considered as a secondary type of polycythemia where there is an impending cause which is responsible for the onset of the disease. Now coming to the secondary polycythemia causes. Now generally high altitude is one of the most important cause for the onset of secondary polycythemia. Now, next to the high altitude, it is the cardiovascular disease which plays a very important role in the development of the disease, especially congenital form of the cardiovascular diseases, what we otherwise refer to as the congenital heart disease, such as atrial septal defect, ventricular septal defect, and platelet ductal arteriosus. Now, the other important causes for the development of secondary polycythemia include heavy smoking, pulmonary diseases with associated alveolar hypoventilation, and also associated renal cell carcinoma, wherein the erythropoietin hormone levels are excessively increased, followed by hepatocellular carcinoma or liver cancer, hydronephrosis, massive uterine leiomyoma. Now, uterine leiomyoma is a benign tumor which is arising from the myometrium of the uterus, and very important cause for the development of polycythemia is dehydration. So, any patient who is continuously dehydrated, probably due to excessive vomiting, diarrhea, severe burns, or due to high grade fever. Now, all these causes are postulated in the development of secondary polycythemia. Now, coming to the clinical features of polycythemia. Now, polycythemia is basically associated with excessive dehydration. So, any patient with dehydrating conditions are prone to develop, as a result of which the primary clinical features include hyperviscosity, hypervolemia, hypermetabolism, and decreased cerebral perfusion. Now, as a result, the patient complains of excessive headache, tinnitus, that is ringing sensation in the ears, visual disturbances, so there is alteration in the vision, sometimes associated with vertigo, syncope attacks, and even it could lead to coma, onset of coma. Now, another important clinical feature is the risk for the patient to develop thrombosis. Now, thrombosis generally occurs due to accelerated atherosclerosis. Now, this thrombosis sometimes could also increase the risk of development of cerebral hemorrhage, as a result of which there could be platelet dysfunction and also associated epistaxis, that is bleeding from the nostrils, peptic ulcer disease, and associated splenomegaly, along with development of pleuritis or itching, especially following a bath. Now, certain patients who present with polycythemia could also have an associated history of hyperuricemia, where the uric acid levels are excessively increased, and sometimes it could be mistaken for the onset of a gout disease. Now, the next point of discussion in the continuation of the topic is the diagnostic findings or laboratory findings. Now, before going to the laboratory findings, there are also certain other types of polycythemia. Now, to name a few, a benign familial polycythemia, generally it is rare, but it also has to be considered before arriving at a diagnosis of the disease. There is also a relative type of polycythemia. Now, the relative type of polycythemia is almost associated with the compensatory type of polycythemia, where probably the cause for the onset of the disease could be excessive dehydration symptoms. Now, coming to the laboratory diagnosis, the basic investigations are of concern. To start with, a complete blood count has to be immediately done on the patient. Now, the hemoglobin values are excessively increased. The normal hemoglobin values as per WHO recommendations for a male, it ranges from 15 grams to 18 grams per deciliter. In a female, it ranges from 12 to 16 grams per deciliter. However, in a patient who is suffering with polycythemia, the counts in a male of hemoglobin analysis or estimation could exceed 18 grams, and in a female it could exceed 16 grams per deciliter. The next investigation in the preliminary category is the erythrocytosis. Now, erythrocytosis is excessive RBC production. So, this is done using a total RBC count wherein the count exceeds 6 million cells in case of males. In case of females, the count probably exceeds 5.5 million. The next investigation is the Paxil volume or the hematocrit. The normal values are seen to be increased. So normally in a male, it could range between 45 to 55%. In a female, it could range between 35 to 45%. Whereas in a patient who is suffering with polycythemia, the Paxil volume could be more than 55% in case of males, and in case of females it can exceed around 47%. The next investigation is the total WBC count. In these patients, the total WBC count is mildly or moderately increased. So we call this condition as mild to moderate leukocytosis. So the count could range anywhere between 15,000 to 25,000 on an average. There is also associated findings in the WBC series such as basophilia, where the basophil content is increased. Likewise, the neutrophil alkaline phosphatase score, which we have already discussed in our previous lectures, is increased. So this neutrophil alkaline phosphatase score was already discussed in the leukemia reaction series, where generally in all leukemioid conditions the count is increased, whereas in a patient who is suffering with chronic myeloid leukemia, the count is decreased. The next investigation of concern is the platelet count. Platelet count are generally increased. This condition is referred to as thrombocytosis. However, the platelet function could be affected. It could be more defective in nature. Now, this is followed by confirmatory tests such as bone marrow findings. there is a bone marrow examination which reveals features of erythroid hyperplasia, and sometimes the patients can also present with pan hyperplasia. Next, we have other confirmatory tests such as cytogenetic studies, wherein cytogenetic abnormalities are recognized in a patient suffering with polycythemia vera, where there could be abnormalities such as trisomy 80, or there could be an abnormality on the 20q chromosome series. Now, apart from this, there is also a mutation on the JAK2 chromosome, and also these patients present with increased erythropoietin hormone levels, especially in serum, and the same hormone levels are very much reduced in a sample of urine. Coming to the next aspect of polycythemia, that is the treatment modalities which are available as on date. Now, initially, these patients were put on phlebotomy therapy, that is, venesection was done in order to reduce the total RBC cell mass, and thereby slowly the patient started developing iron deficiency anemia. Now, the second modality of treatment is the anticoagulant therapy, which is administered especially if the patient shows associated symptoms of thrombosis, which is a very important clinical finding in these patients. Now, the recent treatment modality includes chemotherapy. Now, this chemotherapy is mainly done to induce myelosuppression, followed by treatment with hyperuricosuric drugs in order to reduce the total increase in the uric acid content. So hyperuricemia is treated with uricosuric drugs, and this is followed by a chemotherapeutic drug by name interferon therapy. Now, chemotherapy replaces the interferon therapy. Now, this is associated with very good results, and the treatment is very successful if interferon therapy is started in time in order to reduce the expression of the JAK2 chromosome. Now, this cytogenetic abnormality could be reversed provided the interferon therapy is started in time. Now, generally, coming to the prognosis of the disease, the patient survives on an average around 10 to 12 years following the onset of therapy. Now, 25% of the patients, they are known to develop myelofibrosis, which is a very important complication of the disease, and the remaining patients could also develop associated malignancies such as acute myeloid leukemia, non-Hodgkin's lymphoma, and multiple myeloma. Another major cause and complication, associated complication of the disease is death, which is very common in a patient who is suffering and with associated vascular thrombosis. With this, I conclude my e-content series, and we will meet in the subsequent e-content lectures. Thank you.